Welcome to the Deep Dive, the show that cuts through the noise and gets straight to the most impactful insights for medical professionals. Today, we're plunging into a topic that's incredibly common, yet, well, surprisingly complex: distal radius fractures. These injuries are, let's face it, a ubiquitous challenge in orthopedic practice. They present with just a vast array of patterns, affect diverse patient demographics, and, crucially, require highly tailored management strategies. It's really far from a straightforward diagnosis and treatment, isn't it? Despite how common it seems. Our mission today is to distill the key clinical insights, management pearls, and advanced surgical considerations for mid-senior medical professionals like yourselves. We aim to move beyond just the basic understanding to, truly informed, nuanced practice. To guide us through this intricate landscape, we are incredibly fortunate to be joined by an esteemed expert in orthopedic trauma. Thank you for joining us for this crucial deep dive.
It's an absolute pleasure. This is a topic, well, it's very close to my heart, given its prevalence and the continuous evolution in our understanding and treatment. It really is one of those injuries that looks simple on the surface, but the more you delve into it, the more intricate it becomes.
I couldn't agree more. So let's unpack this right away then. When we talk about distal radius fractures, we're genuinely discussing arguably the most common orthopedic injury out there, aren't we? The sheer prevalence is quite astounding.
You're absolutely spot on. The epidemiology is, well, quite striking, making them a significant public health concern. They account for a notable 17.5% of all adult fractures.
17.5%. Wow.
Indeed. And to put that into perspective, the lifetime risk for women is a significant 15%, while for men it stands at around 2%. What's truly fascinating and perhaps concerning is that the global incidence of these fractures is actually on the rise. We've seen studies like one from Rochester, Minnesota, showing a 17% increase between 1945 and 1994, and more recently, a 2017 study from Sweden noted a 2.0% annual increase in men and a 3.4% annual increase in women aged 50 to 59 between 1999 and 2010.
That's quite a jump.
These aren't just minor shifts. They represent a significant and growing burden on healthcare systems globally.
That's a considerable increase, and it makes you wonder about the underlying factors. When we look at who is experiencing these fractures, it's not a uniform distribution, is it? We often see that distinct bimodal pattern. Can you elaborate on that a bit?
Precisely. There's a distinct bimodal distribution with peaks in two main age groups. We see them in children and adolescents, and then again, quite significantly, in the elderly population. In children, the peak incidence typically occurs around 12 to 14 years old for boys and 10 to 12 years old for girls. This is often attributed to higher energy mechanisms. Think playground falls, sports injuries, maybe even falls from height. It's a period where bone lengthening can sort of outpace mineralization, making their skeletal structure more susceptible to fracture.
Right, more pliable.
Exactly, even from relatively minor trauma. This is particularly true for green stick and buccal fractures, which are incomplete but extremely common in this age group. Then, as we look towards the other end of the spectrum, in the elderly, we primarily see these injuries resulting from low-energy falls, often just from a standing or seated position. This demographic is critically linked to conditions like osteoporosis. Approximately 40% of postmenopausal women, for instance, have osteoporosis. A T-score of less than minus 2.5 on a DeCuzza scan indicates osteoporosis and carries about a 15% 10-year fragility fracture risk.
That's significant.
Very. And other major risk factors in those over 50 include prior falls, previous fragility fractures, long-term corticosteroid use, and simply advanced age. For patients over 75, dementia also emerges as a notable risk factor. What's also notable, and perhaps somewhat surprising, is that women with diabetes seem to have double the risk of intra-articular fractures.
Really? Intra-articular specifically?
Yes, which adds another layer of complexity to their management. So considering increasing life expectancy and, perhaps surprisingly, even childhood obesity leading to greater participation in high-impact sports, the societal impact just continues to grow. It's a multifaceted problem demanding our attention.
So we've got this rising incidence, these distinct demographic peaks. What does this all mean for us clinically? What are the typical mechanisms? Is it always the classic fall on an outstretched hand, the foucher, or are there other patterns we should be vigilant for?
Well, the fouche is indeed the primary mechanism, absolutely, especially in older populations. But it's certainly not the only one. In younger, more active patients, we more commonly see higher energy mechanisms, motor vehicle collisions, cycling accidents, severe sports trauma.
Right.
And it's crucial to remember that a distal radius fracture is rarely an isolated event. We need to be highly vigilant for associated conditions. Distal radial knarr joint, or DRUJ, injuries, for instance, are very common. and radial styloid fractures, often intra-articular. They're strong indicators of a higher energy mechanism because of the scaphoid compressing against the styloid.
Okay.
Furthermore, soft tissue injuries are present in a significant proportion of cases, up to 70% in some series.
70%, that's huge.
It is. This can include tears of the triangular fibrocartilage complex, or TFCC, which occur in about 40% of cases, crucial for DRUJ stability and wrist motion. We also frequently see scapholinate ligament injuries, present in roughly 30% of cases. And there's the possibility of lunotriquetral ligament injuries in about 15% of cases. So a thorough assessment isn't complete without evaluating these potential coexisting issues. Missing them can lead to chronic pain, instability, poor outcomes.
That's a key point, those associated soft tissue injuries, so easily overlooked if you're not specifically looking. Now, beyond the mechanism, understanding the intricate anatomy seems absolutely fundamental, doesn't it? It's not just a simple bone end.
Yeah, absolutely. The distal radius is a cornerstone of wrist function, and its anatomy is highly complex. It transmits about 80% of the axial load from the hand to the forearm. It articulates with the scaphoid, the lunate, and the distal ulna via the sigmoid notch. Understanding this articulation is key, and the three-column concept, popularized by Rickley, really helps us make sense of the fracture patterns and their implications for fixation.
Okay, the 3 columns. Could you break that down for us?
Sure. The radial column includes the radial styloid and the scaphoid fossa. The styloid itself is quite volar, important for pin placement. This column acts as a buttress, resisting radial carpal translation, holding the carpus out to length. Key ligaments like the radioscaphocapitate attach here too.
Right.
The intermediate column is primarily the lunate fossa. This is where the main load transmission occurs. It's also the origin of the vital, short radiolunate ligament, crucial for radiocarpal stability.
Yeah.
Injuries here really impact function. Lastly, the ulnar column comprises the TFCC and the distal ulna. This column is absolutely crucial for DRUJ stability and, critically, for allowing full-form pronation and supination.
Okay.
Without proper function here, those movements are severely compromised, significant functional deficits.
So if I'm picturing this, is the lunate fossa really the Achilles heel when it comes to stability, particularly given its load-bearing role? And you also mentioned key landmarks. Why are those so vital to keep front of mind?
That's a great analogy. The lunate fossa certainly has its vulnerabilities, especially volarly. And yes, specific landmarks are vital because they directly influence our surgical approach and fixation success. Lister's tubercle, for instance. It's a dorsal prominence, about a centimeter proximal to the joint line. The EPL tendon takes a sharp turn just ulnar to it.
The extensor pollicis longus.
Exactly. So during dorsal approaches, or even with long volar plate screws, you have to be acutely aware of it to avoid EPL rupture. It's an attritional thing.
Okay.
Another critical region is the watershed region. That's the most volar prominent aspect of the distal radius. The lunate portion is particularly prominent, gives origin to that short radiolunate ligament. It's paramount that for volar plate fixation, our hardware stays proximal to this region.
Right. Proximal to the watershed.
Absolutely. If the plate is too distal, it can irritate or even rupture flexor tendons, particularly the flexor pollicis longus, OFPL. That's a common and serious complication if not respected.
Okay, so these anatomical nuances are clearly critical for good outcomes and avoiding, well, iatrogenic injury.
They really are.
Given this complexity, it's no surprise we have a plethora of ways to classify these fractures. It feels like every orthopedic surgeon has their favorite eponym or system. Could you walk us through some of the common ones, highlighting their clinical relevance? But maybe more importantly, if we cut through all the names, what's the one thing we should truly internalize about classifying these fractures for clinical decision-making?
Indeed, there are numerous ways to classify them, each with its own, utility and limitations. Eponyms are often used as a historical shorthand. They help memory, but often fall short in conveying severity or guiding surgery. They give a quick picture, but rarely tell you how to fix it.
Right, they're labels, not instructions.
Exactly. Let's start with the common ones. The collis fracture, arguably the most common in adults. Classically Fuchs metaphyseal fracture, about 1.5 inches proximal to the joint. Characteristic dorsal angulation and displacement, the classic dinner fork deformity on X-ray.
Okay, the dinner fork, got it.
In contrast, the Smith's fracture, often called a reverse collis, fall onto the back of the hand or a direct blow, result in volar angulation and displacement, the garden-stayed deformity.
Garden-spade.
These are inherently unstable because the flexor tendons tend to pull that fragment further volar.
Right, exacerbating the deformity.
Precisely. Then we have the chauffeur's fracture, or radial styloid fracture, intra-articular, involving the radial styloid. Historically named after hand crank car injuries, often from a Fuchs with forced dorsiflexion and abduction. The scaphoid impacts the styloid,
Oh.
and it's very often associated with significant ligamentous disruption, radioscaphocapitate ligament, maybe scapholunate disruption, critical to identify, as the ligament injury often dictates prognosis.
So even a small bony fragment can hide a major ligament problem.
Absolutely. A die punch fracture is an intra-articular impaction fracture of the lunate facet, typically axial loading of the lunate onto the radius. Can occur alone, but often associated injuries. Leads to articular incongruity if not fixed precisely. The Barton's fracture. An intra-articular rim fracture, dorsal or volar. Dorsal is more common, forced dorsiflexion pronation. Dorsal rim fractures with carpal dislocation. Volar Barton's is from a fall on a supinated hand. Volar rim fracture with volar carpal subluxation. Both inherently unstable, the carpus falls a fragment.
Okay, unstable rim fractures.
For our pediatric patients, we commonly see green stick and buccal torus fractures, incomplete fractures as their bones are more pliable. Torus or buccal, fractures from axial loading cortex, buccals, minimal deformity. Green stick from bending forces, fracture on the convex side. Concave side intact, very common, easily missed.
Right. Need to look carefully on those pediatric x-rays.
Definitely. And finally, Salter-Harris fractures, involving the growth plate, the physis. Type I to V prognosis and management vary depending on epiphyseal involvement and risk of growth arrest. Now, to answer your crucial question about the one thing, while eponyms are useful shorthand, their clinical relevance for guiding treatment is often limited. Formal systems like Freichmann try to add structure based on articular involvement, ulnar styloid fracture. But even Freichmann is criticized for not accounting for comminution, displacement, and its inter-rater reliability can be poor.
So not perfect either.
Not really. So the ultimate takeaway, especially for orthopedic surgeons, is that a precise anatomic description is often far more useful. Detail the location, open-closed, neurovascular status, angulation, displacement, comminution, impaction, rotation, articular findings like step-offs or gaps, DRUJ integrity.
Right, describe exactly how it's broken.
Exactly. That comprehensive description provides the most actionable information for planning treatment and communicating effectively. It tells you how to fix it.
That makes perfect sense, getting beyond the label. So, once we have that clear anatomical picture, how do we approach the patient? What's critical in the history and physical exam that maybe mid-senior professionals might sometimes overlook, especially given those potential associated injuries?
The initial assessment is paramount.
Yeah.
Goes beyond just the wrist. A thorough history focuses on the mechanism low-energy fall or high-impact trauma. Duration, quality symptoms, any immediate numbness, tingling. Patient-specific details are crucial. Dominant hand, profession, activity level, comorbidities all affect management decisions. And proactively uncover complications. Ask specifically about neurovascular compromise, numbness, tingling, weakness, discoloration. The median nerve is the most commonly injured, often presenting like acute carpal tunnel.
Right, due to the swelling.
Exactly. And in children, subtle presentations, unwitnessed falls, always consider non-accidental trauma. Look for inconsistencies.
Good point. And the physical exam.
Observe any gross deformity, skin tinting, lacerations flags, an open fracture needing urgent attention. Assess for crepitus, tenderness. Crucially, rule out emergent complications. Check for compartment syndrome, palpate forearm compartments. Should be soft. Then, thorough neurovascular assessment. Strong radial pulse. Capillary refill under 2-3 seconds. Detailed neurological assessment. Motor function for radial, median, ulnar nerves. Resisted extension, thumb abduction, finger abduction. Sensation. 2-point discrimination on finger pads, dorsal hand.
Okay, the standard checks.
Yes, but meticulously documented. Normal 2-point discrimination is typically less than 5 millimeters, maybe 6 millimeters in the elderly. Baseline is critical. And finally, don't fixate on the wrist. Evaluate the elbow, carpal bones, hand. Essential to avoid missing coexisting injuries. DRUJ instability, carpal instability, elbow dislocations, proximal forearm fractures like Monteja or Galeazzi.
Right, check the joints above and below.
Always. Quick check of elbow ROM and forearm rotation is warranted.
So after that thorough clinical assessment, imaging. Indispensable. What are the go-to modalities, and what specific radiographic findings truly guide our decisions? What are the key measurements we absolutely cannot miss?
Imaging is our eyes inside, confirming suspicions, guiding strategy, x-rays are standard first line, AP, lateral oblique views, true orthogonal views. From these, several key measurements are vital for decision-making.
Okay, what are we measuring?
Normal radial height, typically around 13 millimeters, measured from styloid tip to ulnar articular surface. We accept less than 5 millimeter shortening. Radial inclination, normally about 23 degrees on AP. Change should be less than 5 degrees compared to the other side. Articular step-off. should be congruous. Less than 2 millimeter step-off is acceptable for intra-articular fractures. More increases arthritis risk significantly.
Right, that 2 millimeter rule.
Crucial. Volar tilt, normally about 11 degrees on lateral. Dorsal angulation should be less than 5 degrees or within 20 degrees at the contralateral side. Loss of volar tilt predicts poor function. We also assess ulnar variance, any shift, look for ulnar styloid fracture, and crucially, check for DRUJ widening or incongruity. Suggests instability.
So those measurements give us the picture of stability.
They provide critical information, yes.
Yeah.
Computed tomography, CT scans are indicated when x-rays are equivocal or strong clinical suspicion, but plain films, unclear, maybe a subtle intra-articular bit. More importantly, CT is invaluable for surgical planning, especially complex intra-articular fractures. Need precise understanding of fragments, combination, step-off.
So the 3D picture.
Exactly. Allows much greater precision in planning the approach and hardware. Magnetic resonance imaging, MRI, generally limited utility for acute fracture diagnosis itself, but highly useful as strong suspicion of associated ligamentous disruption, TFCC tear, scaphoid injury. Usually done outpatient by specialists, rarely dictates immediate fracture management, but key for long-term pain or instability assessment. So it's the combination of meticulous clinical findings and targeted imaging.
That's a comprehensive overview of diagnosis. Moving on to management. Once we've fully assessed things, what are the immediate priorities when a patient presents, particularly in A&E?
Immediate priorities focus on comfort and preventing further harm. First, robust pain management, tailored. Oral 5V analgesia, hematoma blocks injecting local into the fracture site. Ultrasound-guided nerve blocks if reduction anticipated.
Get them comfortable.
Yes. Conscious sedation, often ketamine or intranasal phenylmidazolam for kids, frequently used for painful reductions. Need adequate analgesia, sedation, amnesia. Second, immobilization, crucial after reduction. Well-molded sugar tongue split or short arm cast, more stable than a sling. Third, critically, emergent evaluation for open fractures or neurovascular compromise, open fractures. Gustilo-Anderson scale IPIC guides management. Prompt broad-spectrum antibiotics, tetanus prophylaxis, urgent surgical washout debridement. Grade 2 or higher usually need immediate surgery. Neurovascular compromise. Decreased sensation, motor deficit, pulseless extremity, tense compartments suggesting compartment syndrome. Immediate orthopedic and potentially vascular surgery consult. Pulseless limb or compartment syndrome is a true surgical emergency.
Okay, so manage pain, immobilize, check for emergencies. Now, for many, closed reduction and casting is the initial thought. Who is a candidate for non-operative management, and what are those acceptable radiographic parameters for reduction, and the practicalities?
You're right. For many, especially extra-articular ones, closed reduction and casting is the initial approach. Candidates typically have extra-articular fractures meeting specific criteria, or those with very low functional demands. We're looking for radial shortening, no more than 5 millimeters, dorsal angulation, less than 5 degrees, or within 20 degrees of contralateral, radial inclination change, less than 5 degrees, articular step-off, no more than 2 millimeters, ideally congruous.
So if you can get it there and keep it there.
Exactly. If those parameters can be achieved and maintained, conservative management is often appropriate. The technique of closed reduction needs adequate anesthesia. Muscle relaxation is key. Apply traction, counter-traction, figure traps with weights, or an assistant pulling against the humerus. Goal is to disimpact, restore length. Once length restored, manual manipulation corrects angulation displacement. For collist, typically pronation and volar flexion of distal fragment. Then immobilize in well-molded short-long arm cast or sugar tone splint. Post-reduction x-rays essential to confirm maintenance. A critical point. Avoid extreme flexion and ulnar deviation, the cotton loader position. Increases carpal tunnel pressure, raises risk of carpal tunnel syndrome.
Good practical tip there.
Now, pediatric considerations. Children's bones are much more forgiving, remarkable remodeling potential. Vast majority heal well conservatively, even with some residual angulation. Acceptable angulation limits are more generous, vary by age. Under 10, maybe up to 30 degrees angulation, 45 degrees malrotation. 5-10, less than 25 degrees angulation. Over 10, less than 20 degrees, less remodeling capacity.
It depends on remaining growth.
Exactly. Salter-Harris INT, conservative, often okay if no compromise or incomplete reduction, but attempt only one closed reduction to minimize great plate injury risk. Repeated manipulation can cause damage. One good shot. Higher grades, 3 FV, usually unstable, need surgical fixation. All growth plate fractures need ortho follow-up within 7 days. For incomplete pediatric fractures, green stick torus management also largely conservative, Torus buccal fractures heal in about 3 weeks. Splints usually recommended. Green stick managed conservatively. Splint cast 4 to 6 weeks. Careful attention to age-specific limits. Follow-up x-rays important.
It's fascinating how much more forgiving pediatric bones are. Now, the other side of the coin. When do we know conservative management just won't cut it? What are the key indicators for heading to theater, especially with our understanding of instability and anatomical restoration?
That's the million-dollar question. The decision for operative treatment hinges primarily on radiographic instability and, crucially, the patient's profile functional demands, bone quality. While unstable can be subjective, a fundamental principle is if a fracture needs reduction to be acceptable, it's inherently unstable, high risk of losing reduction, which then means surgery.
Right. If you have to put it back, it probably won't stay there on its own.
That's the essence. Key radiographic indicators. Persistent dorsal angulation, 5 degrees or 20 degrees of contralateral, even after reduction. Significant volar or dorsal comminution, especially articular. Compromises stability, ability to hold reduction. Displaced intra-articular fractures, 2 millimeter step-off or gap, almost always need surgery to restore congruity, prevent arthritis. That 2 millimeter rule again. Radial shortening, 5 millimeter. Critical marker of instability, often needs operative correction. Most predictive finding for instability and loss of function. Associated ulnar fractures causing DRUJ instability can indicate surgery, though isolated ulnar styloid often doesn't, less large or causing clear instability. Severe osteoporosis. Conservative reduction might just not hold in poor bone.
Okay.
Specific unstable patterns, Barton's, dorsalvolar, die punch, Smith's, especially if counted to displaced, and progressive loss of reduction and cast worsening alignment on follow-up x-rays. Clear signal for surgery.
Okay, so if it moves, fix it.
Generally, yes. For younger, active patients, athletes, we tend to be much more aggressive surgically. Higher functional demands benefit greatly from stable anatomical fixation for rapid return to activity. Complex patterns like Galeazzi fracture dislocations almost invariably need acute operative treatment, often reduced, splinted pre-op for soft tissue rest before definitive fixation. It's worth noting predictors of instability, outlined by LaFontaine. Radial shortening, dorsal comminution 50%, palmar intra-articular comminution, dorsal angulation 20 degrees, initial displacement 1 centimeters, 3 or more criteria, higher likelihood of losing reduction. However, important caveat. Some meta-analyses suggest in very elderly, frail patients over 65, maybe no significant difference in functional outcomes between closed treatment and operative methods, particularly for simple extra-articular fractures.
Interesting.
So the decision must be highly individualized. Patient factors, comorbidities, functional demands, not just x-rays alone. It's a nuanced discussion.
That's a great point about tailoring the approach. This is where the rubber meets the road for many listeners. Let's really get into the nuances of operative management, particularly ORF with volar plating, which has become so prevalent. What's the rationale behind this shift to volar plating? How has it evolved?
Indeed, volar plating has truly revolutionized our approach, light years beyond where we were. The rationale for preferring it over dorsal plating is fundamentally anatomical. Critical insight. Dorsally, extensor tendons lie right on the bone. Any plate there can cause constant irritation, adhesions, significant risk of extensor tendon rupture, especially EPL. Historically, a frequent debilitating complication.
Right. Tendon problems were common.
Very. In stark contrast, volarly, the flexor tendons are well separated from bone by the pronator quadratus muscle. This generous space allows robust internal fixation without the same risk of direct tendon irritation. You can place significant hardware with much lower risk of impingement.
Provided you respect the anatomy.
Provided reduction is good and plate placement respects critical landmarks like the watershed line, yes, the evolution of volar plates has been fascinating. Testament to biomechanical engineering. Early simple buttress plates often weren't enough. Comminuted fractures still collapsed, shortened. This led to fixed-angle locking plates. Designs like the pie plate, initially dorsal, sparked the idea of fixed-angle support, though it had its own tendon issues. Quickly gave way to early volar T-plates with fixed-angle options. The key concept emerging was that these fixed-angle constructs provide stable subchondral support, even in highly comminuted surfaces. Creates a rigid scaffold, holding fragments in space, independent of bone quality.
Ah, so the locking screws are the game changer.
Absolutely. Led to a paradigm shift. We realized we could treat many dorsal fractures from the volar side, thanks to this robust stability. My own experience in '97 with an early volar T-plate, designed for volar fractures, gave spectacular results on a dorsal fracture. Confirmed this potential. Designs improved over time. H-plate, biodynamics, DVR, subsequent generations. Now, pre-contoured fixed angle elements often incline distally, providing direct support to dorsal subchondral bone, counteracting dorsal displacement, volar buttressing too. The constant is that fixed angle fixation is paramount for that crucial, stable subchondral support. Allows early motion, improves outcomes.
That's incredible evolution from just holding bits together to creating a true subchondral scaffold. Now, you've spoken extensively on your top tips and tricks for these procedures, drawing from decades of experience. For our listeners deep in the trenches, what are your non-negotiables, your golden rules for optimal outcomes in volar plating? Let's unpack some key principles.
Absolutely.
Yeah.
This is where practical application really makes a difference. Separates good from great outcomes. I've distilled my experience into several key principles or tips and tricks. Rule 1. Know your opponent. Half of these fractures involve the articular surface. That's the challenge. Understand load distribution.
Yeah.
Scaphoid fossa experiences central force, supported by two strong spongy bone columns. Lunate fossa, especially volar aspect, experiences forces offset from the radial shaft, inherently unstable, often supported by only one column.
Okay.
Explains why volar marginal fragments of the lunate fossa are often troublemakers, prone to collapse. Fracture patterns have common lines too. Lunate fossa can split vertically or line exits radially. Volar lunate fragment often largest, most constant. Scaphoid fragment often most displaced. This detail guides reduction and fixation strategy.
So it's not just that it's interarticular, but where specific, particularly that lunate fossa, that dictates difficulty and strategy. Vital distinction.
Precisely. It informs where you need the most robust support. Rule 2. Indicate correctly. True. Many elderly, low-demand patients tolerate deformity non-operatively, shouldn't over-operate. But young, active patients, even osteoporotic elderly with displaced articular fragments, truly benefit from stable fixation. For the young rollerblader, anatomical alignment means rapid return to demanding activity, no chronic pain or arthritis. For the elderly patient using walking aids, stable fixation means regaining function quickly, maintaining independence, reducing fall risk.
Match the intervention to the patient's life.
Exactly. Aim for stable support for the articular surface, regardless of combination, to restore function rapidly, allow early mobilization. Rule 3. Go further, the extended FCR approach. My strong advice. Don't make a competition of small incisions. To treat these properly, especially for optimal access to the volar lunate rim and those problematic volar marginal fragments without needing a separate ulnar incision, you must extend your approach.
Go bigger.
Use a dart incision that crosses flexion creases distally. Paradoxically helps prevent hypertrophic scarring if designed right.
Yeah.
Release the flexor carpi radialis, FCR sheath, and Mercer's fibers distally, FCR attachment to trapezium. Mobilizes FCR and median nerve ulnarly. Gains much more expansive, safe exposure.
Okay.
Identify radial artery, lateral, flexor pollicis longus, FPL. Release septum between FPL, FCR. Elevate thick periosteum, transitional fiber zone, proximal to watershed line. Can often feel this thick layer. Crucially, release brachioradialis from proximal fragment. Sarmientotatus is the primary deforming force. Step cut allows later repair. This comprehensive exposure is key.
So prioritize complete exposure for precise reduction, even if it means a slightly larger incision rather than struggling through a keyhole.
Exactly. Precision over minimal invasiveness if it compromises the outcome. Rule 4. Reach to the other side. Most distal radius fractures, coasis type, are dorsally displaced. Dorsal periosteum intact but foreshortened, contains organized hematoma. This hematoma is a significant impediment to reduction, prevents restoring length, volar tilt.
Right, it blocks the way.
The secret: evacuate that dorsal hematoma. Release contracted periosteum. To do this, pronate the proximal fragment out of the way. Use a bone-holding clamp. Provides direct access to the dorsal fracture aspect from your volar incision. Not trivial, especially in older fractures, but allows debridement, release of contracted dorsal tissues. Critical for maintaining reduction.
So you're working on the back from the front.
Essentially, yes. It's
Yeah.
physiological.
Yeah.
Proximal fragment, blood supplies from anterior and thoracic artery, you're not devascularizing it. For volar fractures, this pronation often not possible. Must lift distal fragment, evacuate hematoma from within joint. More challenging, equally vital. Rule 5. Use the plate as a reduction template. After preliminary reduction, apply plate to proximal fragment. Use a specific maneuver. Thumb on volar plate, other hand on dorsal patient's hand. Translate the carpus volarly. Pure translation, not wrist flexion.
Translate, not flex. Got it.
Incredibly effective for final reduction, restoring crucial 10 degrees volar tilt. Vital for preventing post-op flexor tendon rupture from impingement. Then push distal fragments against the plate. Plate guides reduction, acts as fixed template. My advice: do not commit to the first one. Take your time. Fine-tune under fluoro until anatomically perfect. For volar Bartons, align volar cortex first. Plate reduces volar subluxation. Slide plate distal and ulnar as possible to cover volar ulnar corner, often the key fragment.
So the plate isn't just for holding, but an active tool in reduction. Subtle but powerful distinction.
Absolutely. A precise instrument for anatomical restoration. Rule 6. Temporary fixation and optimal plate placement. Highly recommend temporary K-wires through the plate. Provides immediate stability, confirms plate centering, critically, predicts exact trajectory and placement of final screws. See precisely where distal screws go. Ensure just below subchondral bone, maximum purchase without joint penetration.
Predicts the final position.
It's exactly. Optimal plate placement. Volar approx. 2 mm proximal to watershed line. Screws just subchondral, example, 2 mm below dorsal subchondral plate to capture dorsal fragments. Ensure plate sits at or dorsal to volar critical line. Paramount to minimize flexor tendon rupture risk. Rule 7. Consider from every angle. During reduction, focus on reducing, stabilizing central column lunate fossa first. Provides most immediate stability. Ensure K-wire isn't penetrating DRUJ. Use extended tangential view, forearm supinated, flex elbow till palm touches mini fluoro. Tangential view shows ulnar articular surface, confirms no interarticular penetration.
Neat trick for the DRUJ view.
Very useful. Once the lunate fossa is stable, reduce scaphoid fossa, secure it. Ideally screw to very tip of styloid, robust radial column support. Rule 8. Assure good support structure. Key to modern volar plating. Create subchondral scaffold with fixed angle plating. Don't necessarily chase fix every individual fragment, especially in high comminution. Plate and locking screws hold entire articular surface reduced. Stable support from below. Excellent stability even in osteoporotic bone.
The scaffold concept again?
It's fundamental. Rule 9. Avoid pitfalls. Complications can arise even with a meticulous volar approach. Screw penetration into joint. Major concern. Always assess intra-articular screws with 23-degree elevated lateral view, radiocarpal joint, and skyline view, dorsal cortex. Confirm no dorsal penetration. Proud screw must be changed.
Check, check, and check again.
Absolutely. Tendon ruptures, serious. FPL rupture, most common. Associated with overly distal plate, placement plate edge at or distal to watershed line, direct contact tendon plate. Critical technical pitfall, EPL rupture. From proud dorsal screws, mechanical attrition, even non-displaced fractures, over distraction. Treat with EIP to EPL transfer often. Proud plate, not flat against bone. Often inadequate elevation of perios transitional fiber zone leads to soft tissue irritation, tendon issues. Lastly, watch for volar marginal fragments, especially volar fractures. Often avascular, tend to collapse. Tenuous blood supply. Need rigid fixation for revascularization, prevent delayed non-union.
Okay, several potential traps there.
Vigilance is key. Rule 10. Always have a plan B. Not every fracture behaves. Be adaptable. Old, inveterate fractures, 2 to 3 months. Soft tissue contractures make conventional reduction impossible. Might need to apply plate to distal fragment first, insert distal screws, use plate as lever to reduce proximally, gain length before fixing proximal radius.
Interesting approach for delayed cases.
Necessary sometimes. Remember other methods. Severe comminution, medically unstable patients, spanning external fixators, invaluable for temporization, soft tissue rest, or definitive treatment sometimes. Dorsal Bartons traditionally approach dorsally, but many axial injuries or even dorsal Bartons can often be approached volarly, especially if non-displaced volar fracture line can be opened, converted to extended FCR approach. Leverage volar plating advantages. Finally, bone grafting. Generally don't find necessary if excellent subchondral screw support. Locking plate construct provides stability. Calcium phosphate shows good incorporation if grafting deemed needed for significant voids. Arthroscopically assisted reduction also improving results. Direct visualization of joint surface, precise reduction, address associated ligament injuries.
That's an incredible depth of practical wisdom. It's clear that even with the best technique, not all fractures suit ORF. Beyond volar plating, what other operative methods do we commonly employ? When are they preferred? Advantages, disadvantages?
Crucial distinction. Not every fracture needs or benefits most from ORAF. Other key methods exist. Firstly, closed reduction percutaneous pinning, CRPP. Typically for extra-articular or simple intra-articular fractures, unstable but achieve acceptable closed reduction. Less invasive. Techniques vary. Kapanji infrafocal, pins into fracture site manipulated fragments. Ray hack, pins across fracture into carpus for stability.
Okay, pin.
Advantages. Minimal soft tissue disruption, quicker procedure. Complications. Radial sensory nerve injury risk, pin tract infections, potential loss of production if not monitored carefully, especially comminuted osteoporotic bone, generally less stable than locking plate. Secondly, external fixation, X-fix. often for open fractures, highly comminuted, significant bone loss, medically unstable patients, rigid external frame. Spanning crosses wrist joint for small articular fragment severe comminution. Non-spanning radius forearm only for larger articular fragments preserving some motion. Relies on ligamentotaxies. Ligament tension pulls fragments into alignment. Crucial. Avoid over-distraction. 5 mm carpal distraction, neutral position, prevents stiffness, pain.
Right, don't stretch it too much.
Exactly. Typically can't reliably restore 10 degrees palmar tilt alone. Often combined with pinning or limited plate fixation for better outcomes, articular congruity. Complications, malunion, non-union, significant stiffness, wrist fingers, pin issues, infection, fracture through sight, neuro issues, radial sensory, median neuropathy, usually limited duration, 8 weeks, then cast splint. Bone grafting, sometimes for complex, highly comminuted fractures with significant metaphyseal bone loss or fill voids. Autograft, allograft synthetics, calcium phosphate sulfate. Calcium phosphate shows good incorporation, bioresorption. As mentioned, not routine if locking plate gives excellent subchondral support,
Right.
but useful for severe bone loss. Finally, arthroscopically assisted reduction. Gained popularity, especially intra-articular fractures. Arthroscopically visualize articular surface directly. Precise reduction under vision. Also enables identifying, addressing associated ligament injuries, TFCC, scapholonate, often missed otherwise. Studies show improved results. Articular congruity, detecting soft tissue injuries. Disadvantages. Specialized equipment. Longer learning curve. Potential fluid extravasation. Managed by experienced surgeons.
That's a great overview of the toolkit. Choice of technique, clearly not one size fits all. Now, surgical success is only part of the journey. What does optimal post-operative care look like? What are the common pitfalls or complications we need to watch for as patients recover?
Absolutely correct. Post-op phase is just as critical as surgery for optimal outcomes. Regaining function. Our standard post-operative protocol typically starts immediately. Volar wrist splint, fingers free for early active motion. Week 1, custom molded wrist splint. Occupational therapy starts active ROM wrist fingers. Key is early. Gentle motion prevents stiffness, promotes healing.
Early motion is key.
Crucial. Around week 6. Introduce passive ROM, strengthening exercises, gradually increase load. Week 8. Typically cleared for full activity if healed adequately, ROM satisfactory. Wound care. I favor interrupted buried sutures, dermabond, steri-strips. Good cosmetic result. Avoid suture removal clinic visit. Enhances comfort. Despite best efforts, complications arise. Be vigilant. Median nerve neuropathy, carpal tunnel syndrome, most frequent neurocomplication. 112% low energy, up to 30% high energy fractures, often due to swelling.
Right.
Prevent by avoiding excessive wrist flexional ulnar deviation in immobilization, encouraging early finger motion. If progressive symptoms, worsening numbness, motor weakness, or unresponsive to reduction 24-48 hours, acute carpal tunnel release indicated. Ulnar nerve neuropathy can also occur, often with DRUJ injuries, tendon ruptures, serious concern, EPO rupture higher rate in non-displaced fractures, attrition over sharp edge, or proud dorsal screws. Presents as inability to extend thumb MCPIP. Treat often with EIP to EPL transfer. FPL rupture, closely associated with very distal volar plate placement, distal to waterhead line. Direct contact irritation. Critical technical pitfall. Manifests as inability to flex thumb IP joint. Radiocarpal arthrosis. Develops 2-30% cases, particularly intra-articular. Symptomatic if articular step-off 1-2 mm. Highlights importance of anatomical reduction. Malunion. Intra-articular malunion. Revision of 6 weeks. Restore congruity. Extra-articular angulation malunion. Dorsal 10 degrees from neutral. Leads to stiffness, pain, limited pronation, supination. Treat with opening wedge osteotomy, ORIF, bone grafting. Delayed procedures much harder, higher risks. Radial shortening malunion associated with greatest wrist function loss, degenerative changes. Often need ulnar shortening or radial osteotomy. Other potential complications. East Huey DM entrapment, especially with DRUJ injury ulnar pain. Rare but serious compartment syndrome, immediate fasciotomy. Finally, complex regional pain syndrome, CRPS-RSD. Debilitating. Disproportionate pain, swelling, autonomic dysfunction. Evidence for preventative VIT-C mixed. Prompt physio, multimodal treatments, lidocaine, ketamine, bisphosphonates, sympathetic blocks. Crucial. Very challenging. Really recognition key.
That's a comprehensive and sobering list of potential complications. So what does this all mean for the patient's long-term journey? How can we as a healthcare team optimize their recovery beyond the immediate post-op period for the best possible functional outcomes?
The long-term outlook is quite variable. Heavily influenced by initial injury complexity, patient's biological response, quality of care. Simple extra-articular fractures generally have good prognosis, heal well, often return to near normal function. complex fractures, significant comminution, articular involvement, associated soft tissue injuries, higher risk of poorer outcomes.
Mhm.
Malunion union, persistent decreased function ROM, chronic neuropathic pain, CRPS, post-traumatic arthritis.
Right.
Several factors predict poor functional outcomes. Unfortunately, non-clinical factors. Workers' compensation, low socioeconomic status, lower education levels correlated with less favorable results, highlights systemic disparities. Biologically, low bone density, osteoporosis, also a significant predictor. Bone quality impacts healing, fixation stability. Conversely, successful outcomes strongly correlate with accuracy of articular reduction, restoration of anatomical relationships, and critically early aggressive efforts to regain wrist finger motion via rehab. Compliant patient taking ownership often achieves better results. Also vital. Recognize distal radius fracture in elderly, especially low-energy fragility fracture, as a sentinel event.
A warning sign.
Exactly. Can indicate underlying osteopenia, increased risk for subsequent pathologic fractures, hip spine, even increased overall morbidity mortality. So for older patients, DEXA scan, assessment for bone density issues, strongly recommended. Discuss vitamin D, calcium, potentially anti-resorptives, opportunity for broader health intervention, not just treating the fracture.
That's a critical point, using the fracture as an opportunity for preventative health. Finally, it's clear managing these effectively isn't just the surgeon, it's a true team effort across the healthcare spectrum. What does this coordinated approach look like in practice for the best outcome?
Absolutely. Enhancing healthcare team outcomes is paramount. Frontline providers, A&E, primary care, must be highly familiar with routine management and, crucially, indications for urgent orthosurgical evaluation. First point of contact. Pivotal role in initial stabilization, timely diagnosis, appropriate referral. Recognizing red flags vital.
Mm-hmm.
Effective coordination key throughout journey. Surgeons should proactively educate local providers, emergency nurses on optimal follow-up protocols, when to worry, what to look for, when to refer back. Ensures continuity, timely assessments for healing, complications like median nerve compression or loss of reduction. True teamwork across specialties, emergency docs, GPs, orthopods, anesthetists, occupational therapists, physios, nursing support with robust communication is what ultimately reduces long-term sequelae, optimizes recovery.
Yeah.
In polytrauma, inpatient teams need high index of suspicion for distal radius fractures during tertiary surveys, low threshold for imaging upper extremities to avoid missing these sometimes subtle but significant injuries. Truly multidisciplinary endeavor.
What a truly comprehensive deep dive into distal radius fractures, from the anatomical intricacies and diverse fracture patterns to the precision of modern surgical techniques and the critical role of the entire healthcare team. We've covered so much ground. It's clear that mastering this common injury requires continuous learning and, well, a really keen eye for detail. Perhaps the biggest takeaway here is not just how we fix these fractures, but when the pursuit of anatomical perfection truly matters most for our patients' long-term function and well-being, especially when balancing invasiveness with inherent bone quality and, patient demand. If you found this deep dive valuable, please do consider rating and sharing it to help others discover this important discussion. Thank you so much for your invaluable expertise and for guiding us through this incredibly detailed and insightful discussion today.
My pleasure entirely. Thank you for having me. It's always a privilege to discuss such a critical topic.
And thank you for joining us on the deep dive. We look forward to delving into another critical topic next time.